My name is Sarfraz Khan. I'm going to take the bipolar disorder. To tell you a little bit about myself, I'm working as an associate professor and chairman of Indiana University School of Medicine and Indiana University Paul Hospital. I'm also working as chief of medical services for Meridian. I'm a distinguished fellow of American Psychiatric Association. Bipolar disorder, as a rule, is a very complex disorder. It is multiple types. So some of the types which you may find quite interesting to note, easy to diagnose, may be difficult to treat, but some of the bipolar disorders become a part of your life. You may have a family member struggling with bipolar, you may have a colleague, and you may have people around, just around the corner, who have bipolar disorder and you struggle. So before I go to the management, let me give you a little bit of an overview of bipolar. Many of the people which you see in the movies, many people that you do see in different areas of the world are struggling with bipolar, yet they are able to function for a good period of time. But that good period of time may be excellent when you talk about some situation will look very good, like a good painter, somebody who is an artist, somebody who is a poet, but at the same time, they may be a big failure once it comes to a day-to-day life, dealing with a spouse, dealing with a family, or going to go for work. So I'll try to finish this approximately in 45 minutes or 40 minutes, and after that you should have a time to ask more questions. So many of you may or may not have seen it. This is one of the most famous paintings in the history of the world. This is Starry Night. Starry Night was created by one of the very, very famous painters in the world, of course, and this is something which you do find somewhere in a museum in New York. And this gentleman had bipolar disorder. Bipolar disorder, also known as manic depression, is a mental disorder with periods of depression and periods of elevated mood. The elevated mood is significant and is known as mania or hypomania, depending on its severity or whether symptoms of psychosis are present. To make it very simple, knowing that a student at this time may be from different parts of the world, there's some people who may have a fair baseline and some people may have a struggle. So I tried to get it from Wikipedia. The simplest possible way: mental disorder, which is two extremes. One is depression and second is elated mood, and that elated mood may be mania or hypomania depending upon the severity, and may or may not have a loss of reality testing, which we call a psychosis, which means there may be hallucinations, they may be seeing things, they may be hearing things, they may be delusional, having some false fixed beliefs. Its prevalence in general population is somewhere between 3.7 to 3.9%, and prevalence in patients who have a pre-existing depression is 21 to 26% in primary care setting. Now that may be a bit of a surprising comment which I made. What's the difference between a prevalence in general population versus a prevalence in those people who have a pre-existing depression? What happens in many, not all, but in many of the situations, you do see these people who present with depression in primary care setting, which may be somebody who's in a hospital, or maybe a doctor who's treating somebody in his own clinic. So those people who you diagnose them with depression, in the end, at least one out of those four will end up being diagnosed with bipolar disorder. That may be their usual first presentation is depression, or that may be you fail to take a good history. So we are going back to the very basics, which means taking a history. So when you talk to somebody about, are you depressed? That may be a second question you need to ask, which would be, was there any period of time before going in this depression you felt on the top of the world, super energetic, you believe things have really been great? Just a second. Pardon me. Okay. Unfortunate part, when you do not diagnose somebody with bipolar and you continue to try to treat them for depression, the suicide completion rate in bipolar 1 is very high. It can be, in some studies, 10% to 15%. Now, we need to know that bipolar 1 is not as common a diagnosis. Our usual diagnosis is bipolar 2 or bipolar NOS or cyclothymia or rapid cycler. But once you go to bipolar 1, the completed suicide rate is very high. Knowing at this time that probably I'm at least talking to in two countries, which would be Saudi Arabia and Pakistan, I want to make sure we understand something. The suicide was something which was not as known when we talk about 20 or 30 years ago. You know, the family system was intact. People were able to help each other. They were able to prevent, and in many situations, they were able to talk somebody out when somebody is going through a bad depression. And suicide was more of an illness of the Western world. It is true that suicide is becoming more prevalent in the Western world, but unfortunately, it has been becoming a part in any of the Eastern culture, which at the same time not only means that we are struggling on social level, but at the same time, suicide does lead to a devastation, particularly in the Eastern families, because the family culture is closer, and at the same time, there's one very important factor, which is they may be the only breadwinning member of the family who may attempt or complete suicide. So it does make very clear that you need to carry your diagnostic tools with you so you do not miss anybody with bipolar 1. Otherwise, at least 2 out of every 20 patients will end up, it's not a trial, it means a complete suicide. So you lose 1 in every 100, or in a way maybe 3 in, 1 in every 10, or maybe 3 in every 20 patients who would end up killing themselves by choice. What is your most important struggle? Your most important struggle is inability to diagnose. There are a couple of reasons why you cannot diagnose somebody. The common saying that eyes cannot see which brain doesn't know. So if you're not thinking about bipolar, you're going to miss this. Or you do not have enough time. You're trying to get the things done quickly. You're busy with your patients, you know, your family life waiting. So the most important struggle in bipolar disorder is inability to diagnose. One more factor, when you get somebody, a patient who is difficult to deal with, unreasonable, being disrespectful, and you would like to make sure that he would leave your clinic as early as possible, so that could be another reason there is an inability to diagnose. In a common language, I would say some of them can be intrusive. They can be irritating, and you really would like to get rid of them as early as possible, not knowing that you are setting up a situation where these patients may end up going and killing themselves and may add a bit of a struggle on your side. These are the general types of bipolar disorder. It's bipolar 1, which is by far the severe most form. We have bipolar 2. We have cyclothymia. We have bipolar not otherwise specified. We have rapid cycling disorder. We have mood disorder, NOS, which is the mild most form. And although there still have been a lot of questioning going on about borderline personality disorder, it is at least some people have started believing that it is closely related to one form of bipolar disorder. And what is our most important differential diagnosis? It could be major depressive disorder. Of course, I'm sure you know. If not, then I expect you to go and study depression today. Impulse control disorder. There may be intermittent explosive disorder and substance abuse disorder. To summarize a tiny bit here, major depressive disorder, the presentation of bipolar and major depressive disorder is the same. Many people start with depression and down the road they would be diagnosed. There's of course different studies, and those studies would say that many people with bipolar do not get diagnosed till the age of 34. Like one study says till maybe in the early 40s, but I would stick to probably 30s because they continue to have depression, and if they get a bipolar, you may not know. Impulse control disorder, the people do things impulsively. So sometimes they come to your clinic, they get mad, they get angry, upset, they were impulsive, they leave, and since you do not have somebody who can give you history, you continue to struggle. Well, was that bipolar? Was that impulse control? Intermittent explosive disorder is the same. The crash phase of bipolar and intermittent explosive disorder may have similarities. And in the end, drugs. In the end, drugs. Anybody who's using any drugs, that may be a narcotics, which they can get from the doctor, that may be marijuana, which is, the church, and any of the stimulants, you just name it, including heroin, they can present as bipolar disorder. Bipolar 1, elated mood for over 7 days unless they are treated or hospitalized. Bipolar 2 is less elated mood. It's a milder illness. The manic phase lasts somewhere between 4 to 7 days. There's a rapid cycling bipolar disorder in which there is 4 or more cycles in a year alternating mania, hypomania, and depression, and they kind of come and go relatively quickly. There's a cyclothymia. Cyclothymia is hypomania and mild depression alternating. So you can memorize from, once you start cycling. When you cycle, you're sitting in a bike or on a plane cycle, you would realize that your feet never touch the ground, or on the top, it never goes, kind of out of view. So you can say there's a hypomania, which means doesn't touch mania, and there's a mild depression, and they continue to alternate, and full criteria is not met. Bipolar NOS. This is a form of bipolar, but it does not fulfill the criteria for one or another. And there's a mood disorder NOS. This is a much, much milder form of a bipolar-like symptoms. Of course, it is far hard for you to diagnose somebody with mood disorder because the people may never come and see a physician or a psychiatrist. And then there's a borderline personality disorder. Keep in mind, in borderline personality disorder, there's a self-mutilation. They try to cut themselves, they try to hit themselves, and in many situations, or almost in all situations, there's a history of abuse in the childhood, and in many situations, that is sexual abuse done by one of the family members. So borderline personality disorder is a pervasive pattern of life. They struggle with emptiness in their heart, unable to make relationships, difficulty with dealing with the family members, and sometimes there is a micropsychosis, which means they see things, which can happen in bipolar 1 with psychotic features, but this comes and goes very quickly. I see somebody, it's gone. I'm hearing a voice, it's gone. Okay, we have to have some rule outs. The bipolar disorder may present, and that can be the first presentation of multiple sclerosis. Any lesion which involves right-sided subcortical structure, that can also present as bipolar. The lesions of the cortical areas with close links to limbic system, the use of levodopa, and the use of corticosteroids. Before you diagnose somebody with bipolar disorder, you must ask the question. That is the reason we always say, never diagnose somebody with bipolar till you get a CT scan or MRI of the brain. I understand that in some situations, financially, we cannot afford it. But a very good physical examination can in many situations rule out at least 92, 95, or 98% of the cases. So if you do not have tools, which some Western country may have, that may be the time for you to do a decent physical examination, maybe get an opinion of a neurologist, or learn a very good neurological examination yourself, which will pay you in your lifetime. Now, you really need to find out, again, going back to the history. After getting history of present illness, you've asked substance abuse history, you took past psychiatric history, family psychiatric history. But once you're talking about past medical history, please ask the question. Are you struggling with irritable bowel disease? Are you struggling with ulcerative colitis, Crohn's disease? Do you have asthma? Why? Because the use of steroids is very common in these illnesses. And once they use the steroids, they can very well present with a rage which is associated with mania. Use of ACE inhibitors, diuretics, NSAIDs, and for those people who are using lithium. So, they may look pretty decent, but at the same time, it can push them towards mania, and you would say, gee, the lithium is not working. L-DOPA, Amphetamines, barbiturates, again can they can lead to mania, or they can present like mania. Okay, which substances can present like bipolar? Alcohol, we are aware of that. I understand that in societies where family system is still intact and there have been some punishment associated with the use of alcohol, this is something which is at least not open. But at the same time, there has been enough use of alcohol in any society, as conservative that could be, that it would be hard for you to find out. And on the other hand, the patients will not tell you. So that goes back to how good a history you were taking. Cocaine, amphetamine, and over and above caffeine. You know, extensive use of caffeine. If you get a chance to go to the site of one of the major universities, like Cleveland Clinic, you can find out they have written how caffeine can present as bipolar disorder. They would give the percentages. Okay, there are endocrine conditions: hyperthyroidism, Cushing syndrome, multiple sclerosis, frontal lobe syndromes, Huntington's disease. You may not have seen this disease that often, but I'm hoping that during the rotation of neurology, you would see, or pseudobulbar palsy. This is something which is almost never diagnosed. These are the people who are kind of doing okay with you, then they start laughing hysterically, and you say, gee, that person doesn't kind of look like a reasonable person, or they start crying hysterically. That pseudobulbar palsy is still something which is usually not diagnosed in even countries like United States and Canada. Herpes simplex encephalitis, HIV encephalitis, and syphilis, SLE, hypoglycemia, and hypoxia. These can present like bipolar disorder. However beautiful the strategy, you should occasionally look at the results. You should occasionally look at the results. That's Winston Churchill. And that's a very good saying, that whatever strategy we are trying to make, important thing is, are you making a diagnosis? So we have to be result oriented. The natural course of the disease, it is a variable course. First episode could be mania, could be depression, could be mixed, could be hypomania. Peak age of onset of first symptom is 15 to 19, but as I mentioned before, the first episode is usually depression, and mean age of onset is 21. But mean age of onset and mean age of diagnosis are two very different things. Patient may have an onset at the age of 21. You may not diagnose him till the early 30s. An onset of mania after age 60 is more likely to be an identifiable medical condition like a stroke or CNS lesions. I know I've taken some time, but in my opinion, it was far more important before going to the treatment. At this time, I'm talking from the United States perspective, but I try to make sure that I've written those medicines which I know are available in probably Pakistan and Saudi Arabia. The first one is lithium. It's an FDA-approved treatment. It is used in Pakistan and Saudi Arabia, and that's still a very effective medicine. That is still the gold standard. Second is valproate or divalproxodium, which is Depakote. Then there's carbamazepine, the old-fashioned Decretol, olanzapine, asenapine, risperidone, quetiapine, ziprasidone, and aripiprazole. I'm not sure how many medicines you have. You may have others, but as far as I knew, I think most of them are available except asenapine, which may not be, but sooner or later that will be available in these markets. Now, in the United States, the only FDA-approved treatment for depressed phase of bipolar disorder is these are two things: olanzapine and fluoxetine, the old-fashioned Prozac combo, or quetiapine. So these are the things that clearly mention that we have a lack of FDA-approved treatments. That means everything depends upon you. What would you use? And this is what we are going to discuss in next almost half an hour. Then we talk about maintenance treatment. Before that, we talked about depressed phase. So in maintenance treatment, we have 4 medications which are FDA approved. One is lithium, and we talked about it's the gold standard. There's lamotrigine. This is a medicine which is traditionally used by neurologists for seizure disorder. Olanzapine and aripiprazole. Okay. Now we are talking about mixed phase. Mixed phase is when it is very hard for you to find out is this guy going through a depressed phase or manic? It's kind of, it's a really mixed picture. So we call that as a mixed phase. That would be carbamazepine, olanzapine, asenapine, risperidone, ziprasidone, and aripiprazole. So these are all FDA approved. Having anything FDA approved means nothing. The only thing it means that it has at least 2 studies which they proved that this is better than the placebo. So it is important, but that does not mean that if I have not done a study on medicine A, B, C, and D, and that is not available, that is available, and that's your discretion that you can try to write it down. Okay, we have mood stabilizer, which is lithium, and that's frankly, if I really try to simplify, that's the only thing which falls in that category. But then we have scores of mood stabilizers which are anti-seizure medicines, which may be carbamazepine, which may be divalproxodium, and which may be, there are some others like lamotrigine. Then every mood stabilizer is also antipsychotic. And although things like haloperidol are antipsychotics and can be effective, but we are not using. When I say antipsychotics, I'm talking about second generation antipsychotics. Years and years ago, we used to call them as major tranquilizers, but I think that is an outdated wording. Then we have antidepressants, and then we have anti-anxiety medicines, which are still used for bipolar disorder. So let's go and talk about anti-seizure medicines. I already mentioned that lithium is the only one. That is divalproxodium, that is carbamazepine, that is lamotrigine, that is clonazepam, that is oxcarbazepine, gabapentin, and topiramate. I'm sorry, I know that some of you may be lost by this time. They're really complex names, and you may not be aware of many, but I understand that I think everything so far is available in the countries where you are listening to the lecture. Mood stabilizers, which are antipsychotics too, which is olanzapine, risperidone, quetiapine, ziprasidone, paliperidone, quetiapine, asenapine, and aripiprazole. My apologies, I wrote cerebral twice. Now let's go to lithium, which is the only thing which is a gold standard. It's a naturally acting cation. Its main action is believed to be occurring post-synaptically at the level of G protein and second messenger. So the easier way to remember lithium is it goes through second messenger and it is not metabolized in liver. It is excreted unchanged through the kidneys, and the usual dose is somewhere between 900 to 1200 milligram a day, but range can be as small as 600 milligram and as high as 1500 milligram. Please keep in mind, we have to use this medicine in extended release forms. If you do not use it in extended release forms, you kind of struggle a little bit. Now, it is dosed to get a serum therapeutic range, not by symptoms. So the funny question can be, do you treat the patient or you treat the levels? Now, the perfect answer is you treat the levels. That means patient may not have symptoms, but lithium level starts going up, and that's the time for you to say, I have started panicking. The usual level is 0.6 to 1.2, my apologies. It's 1.2 milliequivalent per liter, but in elderly, you try to maintain it somewhere between 0.4 to 0.8, and this is the level where we try to keep the things more stable. What are the drug interactions? NSAIDs, the over-the-counter brufen, over-the-counter Indocid. These are the medicines which have a lot of drug interactions, and somebody who was stable, got a fever, start using plain brufen, ibuprofen, and they come back and said, I'm not feeling well, I got tremors, and you get the lithium level checked, and you find out it is ranging in the range of 2. Thiazide diuretics. That kind of tends to play a little bit more than probably loop diuretics. Loop diuretics can have some effect too, but thiazide is something very more worried. ACE inhibitors, definitive drug interaction, and calcium channel blockers. That is the plain high blood pressure medicines like Norvasc and others. You have to make sure that they have drug interaction. actions. Okay, this is something which you must need to memorize, because if you do not, your patients on lithium will struggle. It leads to hypothyroidism, common. It leads to renal insufficiency, kidney disease. In the last 4 or 5 years, we have started knowing that renal insufficiency is more common than we anticipated. So somebody whose kidneys done quite well for like 15 or 20 years, after 20 years, they may develop renal insufficiency. So it's very important you keep an eye on urea and creatinine. Parathyroid adenoma. What happens? This leads to hyperparathyroidism. So remember, it's hypothyroidism and hyperparathyroidism. The good part of hypothyroidism is you give thyroid, things work well, and you keep the patient stable. Well, the bad part of hypercalcemia, parathyroid, is that it leads to an adenoma, and in almost all situations, it has to be surgically removed. Then acne. You write it to a younger person, he'll come back and said, I'm unhappy with the medicine, it is really giving me an unsightly look. For teenagers, and if probably you passed through the teenage years, or if you're there, you understand that acne is something which can be very painful. The only difference is the usual acne has all the lesions in different stages of development, but the acne associated with lithium has all the lesions on the same level. Weight gain, very painful. In addition to that, it does block SA node, so that means sick sinus syndrome. So whenever a patient comes back to you, you need to take blood pressure, you need to take the pulse and find out, is there something kind of affecting the heart. It does lead to Epstein's anomaly, and there's a difference. It is statistically significant. Statistically significant means it reaches a percentage where you start worrying. But something which is statistically significant does not mean that it's clinically significant. Just a little while ago, a patient was coming to me, and a very nice girl. She was taking lithium, and she said, I really want to get pregnant, but I cannot because I'm on lithium. And we discussed, and I said, look, it is statistically significant, but the chances that you would actually get Epstein anomaly is pretty low. So would you like to get pregnant? And she and her husband came to my office, we talked, and I ended up giving them lithium. And but she had a healthy baby, and I think baby's now about 2, 3, 4 years old, and it did not have any problem, and it worked quite well. So it is, of course, significant, but clinically the risk is still very low. Lithium toxicity. Now, please try to remember this. Up to 1.2, nothing doing. It's fine. 1.2 to 1.5, and that used to be 1.2 to 1 to 2. So that recently the numbers have been revised. There's a borderline toxicity, mild ataxia, increased tremors. Keep in mind, anybody on lithium has tremors, and very mild tremors. But once those mild tremors becomes coarse tremors, then kind of you start panicking. You say, gee, that doesn't look right. That's probably a part of toxicity, and patient will have a difficulty in walking, so mild ataxia and increased tremors. Then 1.2 to 2 milliequivalent, it's considered mild to moderate. Hand tremors are getting worse. There's dizziness, there's diarrhea, there's ataxia. They start getting confused. Now, from 2 to 2.5, in the older times, we used to say 2 to 3, but now it's 2.5. From 2 to 2.5, there's a moderate to severe. There's delirium, EEG getting abnormal, heart rhythm is getting affected. There is a risk of coma. So what I told you, that do you treat the patient or the level? If you find a level of 3, you need to be concerned, even if patient is looking very good, because maybe next 5 hours, maybe next 8 hours, patient will crash. So you start thinking of, what do you need to do? You stop the medicine, you start giving the fluid, and if you find that things are not improving, right after 3, you go for dialysis. And sometimes there's a question, particularly if you're trying to take the boards for United States of America. Now, above 2.5, which is 3, we talk about severe toxicity and dialysis indicated, which I already mentioned. It can lead to acute renal failure, it can lead to seizures, it can lead to death. In any chance, if you find somebody at the level of 4, it is dialysis. You don't wait a minute, You call the dialysis unit. You would say, I'm sending this patient, we need to start a dialysis right away, or patient will start seizing, patient will go renal failure, and patient may end up dying. A valproate, that code. It's an anticonvulsant used for generalized seizures, so your neurologist knows it well. Usually you try to maintain the level between 50 to 100, but these are not the established levels for mania. Up to 120, sometimes up to 140. You can go and you can use it. The loading dose of 20 milligram per kg per day is given for acute mania. Otherwise, it may be started as 500 milligram twice a day, and you up titrate to 4,000 milligram per day in divided dosages. You can give BID in extended release form, and if this is a regular form, you'll probably give thrice a day. But if you're getting extended release, you can give it twice a day. In acute mania, response rate is similar to lithium and carbamazepine. But carbamazepine, keep in mind, it is not an effective antidepressant, so we don't use it as often. And the baseline workup for divalproxodium is you get a CBC differential, you get complete metabolic panel, you get amylase and lipase and ammonia Y, because it is known to lead to fulminant hepatic failure, which is not that common, but can lead to death. And it can lead to severe hemorrhagic pancreatitis. So both the things can lead to death. Side effects, as I mentioned, liver toxicity, we talked about briefly. You get routine liver function tests and CBC monitoring. Up to 3 times raise in transaminases may be normal, so you don't panic. You just continue to repeat the transaminases. And this hemorrhagic pancreatitis, it can lead to aplastic anemia. It can lead to thrombocytopenia. But keep in mind, this is not like idiopathic thrombocytopenia purpura, because this thrombocytopenia is quite safer than usual. Even at the level of 80, you don't panic. Otherwise, at the ITP, you start panicking at the level of, 60,000 or 80,000. A very well-known divalproxodium leads to weight gain, alopecia, polycystic ovarian syndrome. This is very important. If you're putting a young girl on divalproxodium, please make sure she'll be seen by a gynecologist. Then there's a very evident drug interaction with lamotrigine because it increases lamotrigine level, and what happens? Increased lamotrigine level increases the chance of Stevens-Johnson syndrome, which is rash leading to fulminant Stevens-Johnson syndrome and maybe death. When you're using with carbamazepine and phenytoin, there's a decreased level of Depakote. So these are just something, again, if you're trying to take American boards, this is very important. They're going to ask that question. It will be highly unlikely that these questions are not asked. These are known teratogenic and leads to neural tube defects. The folic acid is 4 milligram per day for women of childbearing age. Sorry for that. Now carbamazepine, Tegretol. It does affect voltage-dependent sodium channels and presynaptic sodium channels. Structure is similar to tricyclics. It has erratic absorption, so we are not big fans of this medicine anymore, and it induces its own metabolism. This is a question they love to ask. So whatever dose of carbamazepine you're given, after a few weeks, you need to increase the dose because it leads to auto-induction. It leads to auto-induction, which means it metabolizes itself. It does affect the enzymes in a way that its metabolism gets affected. Its therapeutic level is 8 to 12 micrograms per ml, and usual starting dose is 200 milligram at night to be increased till levels are maintained. We still have almost a few minutes. Clonazepam. I'm pretty sure clonazepam is available at least in Pakistan. Like Lexartanil, bromazepam. Clonazepam is a high-potency GABA-A receptor agonist. This is used for seizures. This is used for acutely manic patients, and that's a nice benzodiazepine which has much lesser risk of dependence because its effects come slowly and goes away slowly. So the biological half-life is between 15 to 50 hours. Different theories about it. Some people think 38 to 38 hours, but actual biological half-life may go up to 40 to 50 hours, which means it does not give the usual high, which drug abusers would like to have. Like all the other benzodiazepines, it is associated with cleft lip, palatal lip. So if you're trying to give it to a girl who's just married or in a childbearing age, you might like to tell her that, look, I'm giving you this medicine, but if you're planning to get pregnant, there is risk associated, so you might like to know that. It does have a potential of dependency and withdrawal, but it may not be very effective mood stabilizer, but does work. What is the usual dose? Hard to comment. You can use 2 milligrams, you can use 4, you can use 6. It is sedating, so hard to drive. So in many situations, you try to use that in a combination with other medications, particularly for those people who have high anxiety or have another psychiatric illness. Side effects: granulocytosis, liver failure, aplastic anemia, idiosyncratic hepatitis. But that occurs usually in the first month that we're talking about Tegretol. And routine monitoring of CBC and LFTs before starting treatment, and every 2 weeks for first 2 months. Now that does apply to pretty much every medicine what we have talked so far, which means divalproex sodium, which means carbamazepine, which means except lithium. Lithium, you don't get these things done. Carbazepine. I'm not sure if this is available in the countries I'm giving a lecture, but this is a much newer form of carbamazepine, and it could be very effective. I have same side effects of carbamazepine, but main concern is hyponatremia. And then can be bad hyponatremia. Patients can seize, they can get sick. Good thing is, all the medicine which I have discussed so far, category D in pregnancy. Let me tell you the difference. Category A is very safe, and there's nothing very safe in the world when someone is getting pregnant. So maybe water, maybe chicken sandwiches. Category B are safe medicines. We do not have very many, maybe 2 or 3 in the psychiatric world at the most. Category C are most, where we did find abnormalities in the mice, but we did not find in humans, so we have to find the risk-benefit ratio. Category D, which is there is definitive effect. Like if somebody's taking the medicine and getting pregnant, there's a risk that baby may be abnormal. So that would be lithium, that would be carbamazepine, that may be divalproex sodium, that may be clonazepam. But good thing is that trileptal, the oxcarbazepine, is category C, which means after reviewing risk-benefit ratio, you are allowed to use this medicine as long as you discuss with the family. So starting dose is like 300 milligram, and again, there's no lab recommendation, easy to work. But you may keep an eye on CBC with differential and CMP, which is complete metabolic panel, which is sodium, potassium, and then a liver function test. Lamotrigine, very effective medicine for depressed phase of bipolar disorder. You start slow, you go slow. You start as 25 milligram and then increase in increments, which is you go from 25 to 50, then 50 you kind of give a jump to 100. FDA is approved only 200 milligram, but we can use a little more than FDA approved dosage, which is 400 milligram in the morning. And there's a risk of rash and subsequent Stevens-Johnson syndrome, which I briefly mentioned a few minutes ago. It has a drug interaction with valproic acid or divalproex sodium. It is category C, but again, we do not know. It's a newer medicine. It cannot be stopped and restarted by choice. So you have to really slowly up titrate. And it may not be very effective in high phase of bipolar disorder. We do not know. This is not FDA approved medicine. We are kind of not that comfortable. But you always get a baseline of CBC with differential, CMP, Amylase, and Lipase because you're trying to get that in carbamazepine. Then neurontin, gabapentin. Gabapentin is, if ever, it is a weaker mood stabilizer. It does interact with GABA transporter and increased level of GABA. It's excreted unchanged through the kidneys with serum half-life of 6 to 7 hours. Dosing begins at 300 milligram a day, and you can go up to 3,000 milligrams a day. So that's high dose, but you have to give it at least in 3 times a day dosages. Sometimes maybe QID. We don't have any blind trial for efficacy. There's no lab work recommended so far. Topiramate, again an anti-seizure medicine. It inhibits rapid firing of sodium channels, enhances GABA effects of GABA A receptor, but it has failed the trial. It can lead to kidney stones, it can lead to narrow-angle glaucoma, it can lead to cognitive dulling, which means people say, well, we don't kind of understand everything quite good, so they feel a little bit dull. Antipsychotics: Zyprexa, risperidol, Seroquel, Geodon, Invega, Sapphirus, Abilify. The good thing is pretty much all of them are the same when it comes to lab work. You get a baseline blood sugar, you check cholesterol, you need a CBC and CMP, just a precautionary measure. Remember QT prolongation, but there have not been very many reports of deaths with healthier people, but you never know who has a cardiac problem. You may like to get an EKG to start with, so you can kind of watch if there's a QT prolongation. Olanzapine, very effective for acute mania. You give 10 milligram sublingual, it comes in our intramuscular form. It has a lesser incidence of tardive dystonia, and you can use up to 40 milligram in one day. But you need to watch an EKG and you need to make sure a person doesn't fall. It's unlikely to develop diabetes in a short setting, acute setting, but it can, and you might like to keep benztropine in case somebody develops a dystonic reaction, which can be deadly, particularly if this is leading to laryngeal dystonia. Risperidone, again, very effective medicine, and it can be used as an adjunct of an antidepressant, used up to 1 to 6 milligram. Same thing, remember, you always add benztropine when you're writing these medicines. And it has a little bit more risk of tardive dystonia, and above 6 milligram, it acts as a first generation antipsychotic, like the haloperidol. Quetiapine, if you remember, I mentioned this medicine is FDA approved for depressed phase of bipolar. So you may not like to use it when somebody is really, really elated and high. So you start as 300 milligram at night. There is a potential of weight gain, less risk of tardive dyskinesia and tardive dystonia, and may have some effects in mania, but I wouldn't use it not knowing how effective that would be unless we're talking about bipolar 2. Ziprasidone, same thing. The good thing is it has no effects on weight gain, limited effect on prolactin. Once you go back to risperidone leads to raised prolactin, which means the girls can have, even if they're not married, they can have milk coming from the breast. They would be struggling with menstrual cycle. Men can have impotence and they can develop breast. And there are a lot of lawsuits going on in America at this time because of the same side effect. So ziprasidone can be started as 40 milligram twice a day with food, and you have to make sure 350 calories are given, otherwise the absorption is not as good. There's no weight gain. Prolactin sometimes gets affected. Always write benztropine because this medicine has a higher risk of tardive dystonia. Tardive dystonia, which can lead to death, particularly if this is affecting the larynx, the laryngeal dystonia. It has no effect on depression whatsoever, which risperidone has. Paliperidone, this is the same as risperidone, it's the same salt, but it is available in injectable form and very easy to give. And again, it has a propensity of raised prolactin. Again, once this medicine was marketed, they said, well, it is better than risperidol because you will not have any struggle with the raised prolactin, but it turned out to be still pretty bad. Then there's Sapphirus, asenapine. It is used in bipolar, 10 milligram sublingual. Please always check A and C, which means you need to keep an eye on WBC count, and if it drops below 1,000, you need to stop it. Aripiprazole, Abilify, it is used in bipolar 1 and mixed. You must start in at least 15 milligram a day, but it has lesser chance of metabolic syndrome and far better with prolactin. So when you're using in a young boy or a young girl, or people in the ages where they're sexually active, they have their own sexual life going on, so you really do not want to play with prolactin, or they will struggle with impotence or menstrual cycle abnormalities, and they stop using the medicine. Now antidepressants, bupropion is somewhat better. There is believed to be lesser risk of mania, it was a pretty big deal 15, 20 years ago, not anymore, but we watched this. Then, of course, we talked about anti-anxiety medicines, clonazepam, diazepam, which is old-fashioned Valium, Xanax, alprazolam, and lorazepam. These are used with different efficacy, but by far not our first choice. Okay, famous name, The Price of Fame. Bipolar disorder and fame are linked both in present and the past. Virginia Woolf, the famous lady who has written these very famous novels like Mrs. Dalloway and To the Lighthouse. If you have read it, if not, go and read it. It'll add something to your IQ. It has that issue. Von Gogh. Von Gogh was the one who created Starry Night. Another Von Gogh is very famous. It looks like it's a picture. Actually, it's not. He has drawn it with his own hands. And you can imagine somebody back in 1800s. Men and women are more likely than general population to become alcoholics and drug addicts, more at risk to develop high blood pressure, diabetes, ischemic heart disease. These are the things which I've used to prepare this lecture. The first one is Massachusetts General Hospital Psychiatry. That's Harvard University's board preparation course, Kaplan and Saddock's, and APS practice guidelines, and Handbook of Psychiatric Drug Therapy. So if in case I'm positive, at least some of these medicines books are available in Saudi Arabia and Pakistan. Okay, I am ready to take questions. Daniel, I'm keeping my phone in my hand in case we struggle and to make sure I take the questions.
Sure.